If you spend any amount of time, scrolling through digital ads or reading lifestyle articles, you've almost definitely seen it.
Oh,
Yeah,
absolutely.
this phenomenon of the pink pill. And the marketing for it is, it's incredibly consistent.
Sleek imagery, very persuasive copy.
Exactly. And the core claim is always pitched as this revolutionary breakthrough for female sexual dysfunction. Like, it's the female equivalent to the little blue pill.
Which is a huge claim to make.
Right. They promise this complete revitalization of sexual health and intimacy for you. And it really sits at this fascinating intersection of, well, pharmacology and just pure consumer marketing.
Yeah, it really does.
So today, for this deep dive, we are pulling apart the mechanics, the biology, and the actual regulatory realities behind those claims. And this whole analysis is powered by the iMedix platform.
Which is such a fantastic resource.
It is. It's an independent medical information database that's really focused on patient education and medication safety. Our mission today is to help you master medication safety discourse. We're going to bypass all that promotional language and examine the raw pharmacological profile of this drug.
Because the necessity of platforms like iMedix really becomes obvious when you look at how easily complex medical interventions get reduced to sound bites.
Oh, definitely.
Medication safety requires a real understanding of what a compound actually does at the cellular level, how it interacts with your systemic physiology.
And the risks.
Exactly. The inherent risks of self-medicating when you don't have a doctor's oversight. So we're using the iMedix database to conduct a forensic examination of a drug commonly branded as Lovegra.
Though you might also see it as Lady Era.
Right, or simply marketed as female Viagra.
Yeah.
We're going to look at its mechanism of action, the pharmacokinetics, the severe adverse events, and really the broader implications of repurposing vascular medications for such complex conditions.
And I think the most critical piece of data from the iMedix database, it really fundamentally reorients this entire discussion.
It's the big reveal.
It is. Lovegra is not a novel chemical entity. It's not some newly synthesized compound developed specifically for female biology.
Not at all.
The active ingredient is simply sildenafil citrate.
Yep.
That is the exact same phosphodiesterase type 5 inhibitor, or PDE5, that has been prescribed for decades to treat erectile dysfunction in men.
It's the exact same thing.
Right. The manufacturing process basically just takes the existing sildenafil compound, formulates it into a pink tablet, and applies this highly targeted marketing campaign directed at women.
It's pure branding.
Yeah, it's an exercise in drug repurposing driven by marketing rather than actual chemical innovation.
And the regulatory status of that repurposing is really the first major red flag we need to talk about.
It's a huge one.
Because the application of sildenafil citrate for female sexual dysfunction is explicitly off-label.
Right.
Neither the FDA nor the European Medicines Agency has approved sildenafil for this specific indication.
Zero approval.
Exactly. The rigorous clinical trials you'd need to establish definitive efficacy, long-term safety, and optimal dosing for women, they just haven't resulted in a formal regulatory sanction.
Yeah.
So when a physician prescribes this, or when you as a patient procure it independently, you are using a medication outside of its approved clinical umbrella.
Which, to be fair, off-label prescribing is a standard practice in medicine.
Oh, sure.
Doctors frequently use approved drugs for unapproved indications based on, their clinical judgment and emerging research.
Right.
The drug itself is legally manufactured.
Right.
Where it goes off the rails is the marketing and those widespread distribution networks capitalizing on the off-label status without comprehensive safety data for women.
Exactly.
But to understand why it's prescribed off-label at all, we really need to look at the mechanism of action, because sildenafil is a PDE5 inhibitor.
Let's break down those cellular mechanics.
Yeah, so we have to look at the nitric oxide pathway.
Oh.
During sexual stimulation, nitric oxide is released into the vascular smooth muscle. And this activates an enzyme called guanylate cyclase, which in turn increases the levels of cyclic guanosine monophosphate, or cGMP.
Which is the key player here.
Exactly. It's the cGMP that actually causes the smooth muscle in the blood vessel walls to relax. That leads to vasodilation and increased blood flow.
And then PDE5, or phosphodiesterase type 5, is the enzyme responsible for degrading that cGMP.
It breaks it down.
Right. So by introducing sildenafil, you introduce a competitive inhibitor that binds to the PDE5 enzyme, preventing it from breaking down the cGMP.
So it just builds up.
Exactly. You get an accumulation of cGMP, which sustains the relaxation of the smooth muscle and prolongs the vasodilation.
Right.
In male anatomy, this facilitates the engorgement of the corpus cavernosum. In female anatomy, the clinical theory driving the off-label use is that this same sustained vasodilation will increase blood flow to the clitoral and vaginal tissues.
That makes sense mechanically.
The goal is to induce engorgement of the vestibular bulbs and clitoral network, theoretically enhancing physical sensitivity and promoting natural lubrication.
I always like to think of it through a plumbing analogy. The drug is essentially upgrading the plumbing in a house. It expands the capacity of the local blood vessels and reduces vascular resistance.
That's a great way to put it.
But, and this is crucial, expanding the vascular capacity doesn't automatically turn on the tap.
No, it doesn't.
The nitric oxide pathway we just talked about requires an initial trigger. The drug doesn't initiate the release of nitric oxide.
Right.
It only amplifies the downstream effects once the nitric oxide is already there.
Right.
So without initial sexual stimulation, whether physical or psychogenic, the drug remains physiologically completely inert.
It does nothing.
Right. It requires that endogenous neurovascular cascade to begin before it can actually do its job of inhibiting PDE5.
And that reliance on the endogenous cascade really highlights a profound clinical misconception, which iMedix identifies as a huge safety concern.
The arousal versus desire issue.
Exactly. The branding of these pink pills heavily implies that they function as aphrodisiacs, like instant mood creators.
Right.
Patients often buy sildenafil expecting it to modulate their psychological desire or artificially induce arousal in their brain chemistry.
Which it absolutely cannot do.
It has zero mechanism of action that crosses the blood-brain barrier to influence dopamine or serotonin.
And the medical categorization of female sexual dysfunction separates these issues very clearly.
Yes, it does.
You have female sexual arousal disorder, or FSAD, and hypoactive sexual desire disorder, or HSDD.
Right.
FSAD is primarily a physical difficulty. You can't attain or maintain an adequate physical response. The psychogenic desire is there, but the localized neurovascular response, the vasodilation, is impaired.
That's the physical side.
And that is the very specific narrow physiological window where a peripheral vasodilator like sildenafil is theoretically targeted. It's trying to correct a localized vascular deficit.
But HSDD, on the other hand, represents a persistent deficiency or absence of sexual desire, which causes marked distress.
It's rooted in the brain.
Entirely. The etiology of HSDD is vastly more complex. It involves a delicate balance of excitatory neurotransmitters like dopamine and norepinephrine and inhibitory ones like serotonin.
Right.
It can be influenced by endocrine fluctuations, menopause, chronic stress, relationship dynamics, or even side effects from other medications like SSRIs.
So introducing a peripheral vasodilator to treat HSDD is just tackling the wrong problem entirely.
A fundamental mismatch of pathology and pharmacology. It cannot fix libido.
And if we look at the treatments that are actually approved by the FDA for HSDD, the contrast is staggering.
That's night and day.
The iMedix database references flibanserin, which is marketed as A. Flibanserin operates entirely within the central nervous system.
Right.
It's a 5-HT1A receptor agonist and a 5-HT2A receptor antagonist. It modulates serotonin and dopamine levels in the prefrontal cortex to literally alter the brain's reward and desire pathways.
And you have to take it daily.
Exactly, to gradually shift the baseline neurochemistry. Sildenafil, which works strictly in the peripheral vascular system on an on-demand basis, cannot replicate that.
And the consequence of this widespread misunderstanding is that patients with HSDD, which is a huge portion of women with sexual dysfunction, will seek out sildenafil, experience zero improvement in their libido, and expose themselves to severe risks for no reason.
Which brings us to a massive, massive red flag in the iMedix reports.
The dosage.
The dosage discrepancy is terrifying.
It really is. Lovegra and similar off-label products are almost always sold online as 100 milligram tablets.
Which is shocking.
Let's put that into clinical context for you. In approved male applications, 100 milligrams is the absolute maximum ceiling for a single dose.
The absolute limit.
Doctors almost always start patients at 25 milligrams or 50 milligrams to test their tolerance.
Right. You have to evaluate hepatic and renal clearance rates, monitor for hemodynamic shifts.
You can't just jump to 100. Initiating therapy at the maximum 100 milligram threshold without any preliminary screening subjects the cardiovascular system to an abrupt, profound pharmacological stressor.
It's so dangerous.
The incidence rate of adverse events scales directly with the plasma concentration of the drug. Bypassing that titration phase maximizes the risk of severe hypotensive episodes.
And there are strict rules about usage, like the 24-hour rule.
Right, never more than one tablet in 24 hours.
Because the half-life of sildenafil is roughly 3 to 4 hours, but its terminal clearance takes much longer.
Stacking doses circumvents the body's metabolic pathways. It leads to toxic plasma accumulation. Taking more doesn't increase the benefits.
It just spikes the risk.
Yeah.
And it's also highly susceptible to gastrointestinal variables.
This is a really practical point.
Sildenafil absorption is significantly delayed by lipids. If you take that 100-milligram dose after a high-fat meal, gastric emptying is delayed, and the time to reach peak plasma concentration can be extended by over an hour.
Which leads to terrible patient behavior.
Exactly. If the response doesn't happen in that expected 30 to 60-minute window, a patient might think, oh, the dose was too low, and take a second tablet.
And then the gut processes both doses.
And the resulting spike in plasma concentration can easily trigger a hypotensive crisis.
And we have to talk about how you, the listener, might actually encounter this drug.
The wild west of the internet.
Because primary care docs and gynecologists are usually hesitant to prescribe this off-label without a very compelling clinical rationale.
Right.
So patients search where to buy female Viagra online, and that drives them to the unregulated digital marketplace.
Purchasing prescription-grade PDE5 inhibitors from unlicensed international vendors.
It removes all quality assurance.
The toxicological risks of this black market are well documented in iMedix. You're exposed to counterfeit pills that lack good manufacturing practices.
A tablet stamped 100 milligrams might have barely any active ingredient.
Or it might have 200 milligrams.
Exactly.
And chemical analyses of these intercepted counterfeit pills often reveal undeclared contaminants, heavy metals, commercial solvents from clandestine labs.
Or completely different active ingredients.
Like glyburide.
Yes, the diabetes medication.
Which can cause fatal hypoglycemia in non-diabetic individuals. It's terrifying.
But even assuming you get an unadulterated 100-milligram dose of sildenafil, we have to look at the side effects, because a systemic vasodilator isn't anatomically isolated.
Right, goes everywhere.
The PDE5 enzyme is all over your systemic circulation. Inhibiting it decreases peripheral vascular resistance globally.
That systemic ripple effect is what causes the common side effects.
Yeah.
Headaches, because of the profound dilation of the cranial vasculature, altering intracranial pressure.
Facial flushing.
Yeah, the cutaneous capillary beds in the face and neck engorge with blood, so you get red and warm.
Nasal congestion, too.
Because the erectile tissues in the nasal passages swell. You get indigestion because the lower esophageal sphincter relaxes. Muscle and back aches.
And while those are nuisances, the peripheral vasodilation can precipitate real medical emergencies.
Let's talk about the severe reactions.
We have to address priapism. People associate it with male anatomy, but it is highly relevant to female physiology.
Because the clitoris and vestibular bulbs are comprised of homologous erectile tissue.
Exactly. A severe response to high-dose sildenafil can result in persistent, painful engorgement of these tissues lasting over 4 hours.
Which is female priapism.
Right. It's a localized compartment syndrome. The arterial inflow of blood continues, but the veno-occlusive mechanism fails to release it.
The blood gets trapped.
It becomes deoxygenated, leading to localized ischemia. If you don't get emergency ER tissue-saving treatment, which often means aspirating the blood to relieve pressure, the cellular necrosis can cause permanent tissue damage and irreversible sensory loss.
That's horrifying. And the ischemic risks don't stop at the pelvic region.
No, the iMedix documentation explicitly warns of NAI on
non-arteritic interior ischemic optic neuropathy.
Right. It's a sudden drop in blood pressure combined with vascular dysregulation that compromises the optic nerve head,
resulting in sudden, painless, potentially irreversible vision loss in one or both eyes.
And disruptions to the microvasculature in the cochlea can cause sudden sensorineural hearing loss,
often accompanied by severe tinnitus and vertigo.
Exactly.
We also have to evaluate cardiovascular strain. Sexual activity naturally elevates your heart rate.
Right.
When you combine that physical exertion with a high-dose systemic vasodilator that aggressively lowers your blood pressure, your heart has to pump much harder and faster to keep blood flowing to your brain and vital organs.
It's a compensatory tachycardia.
And superimposed on the physical exertion, it can trigger a severe mismatch in the coronary arteries.
If you experience radiating chest pain, profound shortness of breath, or acute nausea during sexual activity after taking this, it indicates a potential myocardial infarction.
You need immediate emergency resuscitation.
Which segues into our absolute no-goes, the drug interactions.
Yes, the fatal mix.
The iMedix database is very clear on this. There is an absolute contraindication between sildenafil and any organic nitrate medication.
Medications for chest pain like nitroglycerin.
Or recreational alkyl nitrates, commonly known as poppers. These operate as nitric oxide donors. They flood your system with nitric oxide, driving massive cGMP production.
So if you introduce sildenafil into an environment already flooded with nitric oxide, you completely paralyze your body's ability to regulate that vasodilation.
Exactly. The sildenafil prevents the degradation of all that cGMP.
It's a synergistic accumulation that causes a sudden, life-threatening drop in blood pressure.
Your blood pressure drops to levels that simply cannot sustain cerebral or coronary perfusion. It leads to immediate syncope, ischemic stroke, or fatal cardiac arrest.
And it's not just nitrates. Alpha blockers, which are often prescribed for blood pressure or prostate issues, they inhibit the sympathetic nervous system's ability to constrict blood vessels.
Right.
Taking sildenafil with an alpha blocker creates an additive hypotensive effect. You lose your compensatory vasoconstrictive reflexes, leading to severe orthostatic hypotension.
You stand up, your blood pressure bottoms out, and you faint.
Exactly. And then there's the hepatic metabolism vulnerability.
The cytochrome P453A4 system.
Right. The CYP3A4 enzyme in the liver clears sildenafil from your system. If you take a CYP3A4 inhibitor, you're shutting down the pathway that eliminates the drug.
This includes certain antibiotics like clarithromycin, antifungals like ketoconazole, or antiretrovirals like ritonavir.
The drug just gets trapped in your system and toxicity spikes.
And this isn't restricted to prescription meds?
No, dietary interactions are huge here.
Grapefruit juice is a potent, irreversible inhibitor of intestinal CYP3A4.
Drinking it before taking sildenafil leads to a massive increase in systemic bioavailability, mirroring that toxic accumulation.
And alcohol acts as a central nervous system depressant and a peripheral vasodilator.
So mixing alcohol and high-dose sildenafil amplifies the dizziness and hypotension.
And it blunts your sensory nervous system, which totally counteracts the arousal effect you wanted in the first place.
Not to mention the special populations where this is completely unsafe.
It is strictly contraindicated during pregnancy. Its safety regarding fetal development hasn't been established.
Nor has its impact via breast milk. And obviously, anyone under 18 shouldn't be using this.
And the elderly require much lower starting doses due to slower drug processing times. An older adult taking 100 milligrams will experience sustained elevated plasma concentrations.
You also shouldn't be driving or operating machinery after taking it.
Definitely not.
Which really leads us to ask a crucial question here. What if sexual dysfunction is actually an early warning system for the body?
That is the most insidious part of this whole phenomenon, masking the real problem.
Right. Because when you use a high-dose vasodilator from an unregulated source to forcefully induce blood flow, you're engaging in aggressive symptomatic masking.
Endothelial dysfunction, the inability of your blood vessels to properly dilate, rarely stays isolated to the pelvic region.
It's a systemic issue.
Yes. In vascular medicine, localized endothelial dysfunction is widely recognized as a precursor to systemic atherosclerotic disease.
The arteries supplying the pelvic region are smaller in diameter than your coronary or carotid arteries.
So they exhibit symptoms of vascular occlusion much earlier. A sudden onset of physical arousal difficulties is frequently the first clinical manifestation of undiagnosed hypertension.
Or advancing type 2 diabetes.
Or impending coronary artery disease. Or clinical depression.
It's a canary in the coal mine. And by masking the symptom with a pink pill, you're delaying the actual diagnosis.
You force the compromised vessels to dilate, temporarily getting the physical response, while the underlying disease progresses undetected.
The iMedix documentation emphasizes how crucial medical oversight is. There are no natural equivalents to prescription sildenafil.
No, there aren't.
You need a proper medical evaluation with a primary care doctor or gynecologist to find the root cause, whether it's vascular, hormonal, or psychological.
You have to treat the root cause, not suppress the warning system.
To really ground all this clinical data, I want to bring the conversation back to human experiences by looking at some user reviews from the iMedix database.
Real-world application is so important to look at.
Let's unpack the review from a user named Chloe. Her doctor actually suggested trying it.
Which is a highly instructive case study. It shows that supervised off-label utilization does happen safely in clinical settings.
Right. Her physician evaluated her, ruled out interactions with CYP3A4 inhibitors or nitrates, and established a safe dosing parameter.
That supervised environment directly mitigates the catastrophic risks of those black market 100 milligram pills.
In a review, Chloe noted experiencing mild facial flushing.
Which perfectly corroborates the expected pharmacokinetic profile. It's that cutaneous vasodilation we discussed.
But because she was on a safe, titrated dose, it was just a mild warmth, not a severe headache or a hypotensive crisis.
The drug behaved exactly as it should within safe margins.
But the psychology versus physiology aspect of her review is fascinating. She said it made her feel more vibrant and relaxed.
And sildenafil has zero anxiolytic or sedative properties. It doesn't relax your central nervous system.
So how much of her positive experience was physiological, the increased blood flow, versus psychological?
You have to look at the biopsychosocial lens. The sympathetic nervous system drives performance anxiety and stress, causing vasoconstriction. That opposes arousal.
Right.
But by consulting her doctor, getting a diagnosis, and taking a prescribed step, Chloe probably experienced a huge drop in that anxiety.
The placebo effect of taking action.
Yes. The psychological permission to relax shifted her into a parasympathetic state, which is required for arousal. The vibrant feeling was likely a synergistic result of the drug's vasodilation, coupled with the profound relief of having a medical strategy.
It just highlights how impossible it is to separate the vascular from the psychological in human sexuality.
You really can't.
And the community discourse on iMedix reflects how vital this education is. There's another user, Zach, who simply commented to thank the platform for the information.
Zach's engagement really underscores the public health value of these platforms.
It does.
Whether you're a patient, a partner, or just someone navigating the online market, having access to rigorous, mechanism-based pharmacological data is a critical harm reduction strategy.
Education disrupts the marketing hype.
Exactly.
So synthesizing this massive amount of information today, the contrast between pharmaceutical marketing and medical reality is stark. Lovegra is just a repurposed off-label male drug.
Sildenafil citrate.
It has real physiological effects, altering the hydraulic capacity of the local vasculature by inhibiting PDE5, but it is entirely ineffective for treating low desire or altering your neurochemistry.
And buying unregulated 100 milligram doses online exposes you to significant unmonitored risks.
From hypotensive episodes and vision loss to fatal drug interactions.
And it masks the root causes of sexual dysfunction.
All this data was sourced directly from the iMedix platform. We highly encourage you to use their educational resources to master medication safety for yourself.
We really do.
Before we sign off, I think there's a final lingering question we need to ponder based on all of this.
I think there is a broader structural question here. If a purely physiological drug designed to treat a mechanical vascular deficit in men is simply painted pink and heavily marketed to women, without addressing the incredibly complex, multifaceted nature of female desire and psychology, what does that say about how the modern pharmaceutical market views women's sexual health?
Are they prioritizing genuine scientific advancement or just looking for the easiest way to repurpose existing assets?
It really makes you wonder if they're just oversimplifying female physiology for a profit.
That is a critical framework to carry forward. Understanding the cellular mechanics is the first step in demanding better, more appropriate medical interventions. Thank you for joining us for this deep dive. Keep critically evaluating the medical information you encounter, and we'll see you next time.